Many factors may be involved in the formation of kidney stones. The chemical composition of urine is strongly influenced by different dietary habits. Nutritional habits can vary due to heritage diets, population geographic isolation, and social and economic factors. In addition to kidney biofunctional epigenetic factors, it is necessary not to underestimate congenital intestinal factors. The escaped widespread use of food additives should be taken into account to ensure a correct lithiasis diagnosis and set up a valid treatment and an appropriate nutritional plan. This figure shows the results of a multivariate analysis between alimentary intake and the effect of the same elements in urine. As expected, the recurrent presence of fruit and/or vegetables in the diet correlated with urinary citrate levels, although this failed to reach anti-lithogenic levels in some subjects. The causes of citrate reduction are linked to epigenic and familial factors by increased intestinal reabsorption at the brush border of the small intestine and by tubular sodium dicarboxylate cotransporters. Dietary calcium intake is correlated with sulfaturia, uricosiuria, azoturia, and ammoniuria, especially in the consumption of calcium-containing foods such as poultry, milk, and dairy products. The correlation between calcium and sulfur is of particular interest due to the wide use of calcium sulfate as an additive in the form of sulfuric acid, sodium sulfate and bisulfate, potassium sulfate, calcium sulfite, and bisulfate. Other common additives include ammonium and calcium polyphosphate, ammonium carbonate, and/or ammonium hydrogen carbonate. Several commonly consumed foods featuring a high calcium and protein content correlate significantly with the urinary excretion of nitrogen. Magnesium is the second most abundant cation in vertebrates. Oxalate reduction is initiated at the intestinal level, with both calcium and magnesium binding to oxalates, resulting in increased fecal excretion and a consequent decrease in the kidney, and increased reabsorption of calcium and phosphorus in the ascending segments of the proximal tubule. Magnesium indirectly inhibits PTH secretion, thus reducing the stimulating effect of sodium-dependent cotransporters on the intake of magnesium-containing foods and the presence of urinary urea nitrogen and urinary ammonia. It is likely that the presence of magnesium in all foods of animal and plant origin has resulted in a renal imbalance between magnesium intake and azoturia. The link between potassium and oxaluria may not only be due to eating habits and a preference for plant-based foods containing high amounts of potassium and oxalates. On reaching the kidney, potassium is almost wholly reabsorbed along the proximal convoluted tubule and ascending Henle loop. The correlation between a diet rich in potassium-containing plant foods and increased risk represented by high levels of oxalates is indisputable. It is a well-established fact that protein intake results in an increased excretion of urea and ammonium. There is a very strong correlation between daily protein intake and the sum of renal and extrarenal nitrogen outputs. Optimal practical procedures include the following. Perform urinary metabolic tests only in highly specialized laboratories. Calculi composition must be performed only using infrared ray spectrophotometry. The diet of patients affected by nephrolithiasis must consist of fresh foods without additives, as additives can make biological analyses less reliable. The nephrological path is not complete without consulting a nutritionist expert in food plans and considering the type of lithiasis. Food and hydroponic therapy must be accompanied by therapies and foods tailored to the type of lithiasis. To set up complete diagnostic and therapeutic procedures, always consider geographic isolation, heritage diets, kidney and intestinal epigenetic factors, and the widespread use of food additives.